Okay, let's just jump right in. Because if you're watching this explainer, you probably already know the deep, exhausting frustration of seeking answers for chronic pelvic pain. For way too long, people dealing with complex pelvic conditions have just been brushed off. But today, we're taking a strictly medical, evidence-based approach to demystify three highly distinct, yet frequently overlapping conditions. We're looking at endometriosis, adenomyosis, and chronic endometritis. By actually looking at the biology and the imaging, we're going to make sense of all this chaos.
We absolutely have to dismantle the myth that severe, life-altering pelvic pain is just a normal part of having a period. The clinical sources are crystal clear on this. These conditions affect so much more than just a few days of bleeding a month. I mean, they dictate your pain processing, your energy levels, digestion, bladder function, fertility, basically your entire quality of life. So the very first step is acknowledging that we are dealing with complex, chronic diseases.
To really wrap our heads around what's happening in the body, we need to map out exactly where these three conditions live. Because, well, they share similarities and often show up in the exact same person, but they operate in completely different biological territories.
If we were to draw this out on a whiteboard, imagine sketching extra tissue scattered entirely outside the uterus, wrapping around the neighboring pelvic organs. That is endometriosis. Now imagine drawing deep roots infiltrating right into the thick, muscular wall of the uterus itself. That's adenomyosis. And what if we draw inflammation sitting right there inside the inner lining? That is chronic endometritis. So endo is outside, adeno is in the muscle, and endometritis is in the lining.
Think of your uterus like a house. Endometriosis is like these aggressive, irritating weeds growing all over your yard, wrapping around the plumbing and completely changing the environment outside the home. Adenomyosis is when the actual structural walls of the house become thickened, swollen, and compromised. And chronic endometritis? Well, that's like the inner wallpaper of the house becoming damaged and inflamed, which makes it a really hostile environment for a pregnancy to implant.
Let's grab our magnifying glass and zoom in specifically on that muscle wall to see what adenomyosis actually looks like clinically.
Notice the focus on the junctional zone right here. Under normal, healthy conditions, this is a really thin, smooth, well-defined boundary line that separates the uterine lining from the thick muscle layer. But when someone has adenomyosis, that endometrial tissue essentially invades the muscle. And because of that, this once smooth boundary line becomes blurred, totally irregular, and markedly thickened. The entire structure is just disrupted.
So if your doctor's using expert transvaginal ultrasound or an MRI, they are looking for highly specific visual clues. They actually measure that junctional zone, and anything over 12 millimeters is a massive red flag. They're also looking for fine, dark lines extending into the muscle that literally look like the slats of a Venetian blind. Those represent disrupted muscle fibers. And if they spot tiny microcysts smaller than 3 millimeters scattered in the muscle, or if the uterus has taken on this bulky, globular shape, well, adenomyosis is highly likely.
Now, shifting our focus outside the uterus, we run into endometriosis. And honestly, this is where things get incredibly complex. Even though it's technically categorized as a benign disease, researchers note it often behaves with cancer-like invasion.
Because these rogue lesions can implant on practically any organ in the pelvis, it triggers a massive immune cascade. It isn't just sitting there, it's actively communicating. It creates inflammation, sticky scar tissue, and severe nerve irritation. This is exactly why someone might experience intense bowel pain, painful urination, or deep nerve pain shooting down into their back or legs. The disease is literally growing on and irritating those specific anatomical structures.
Looking at actual clinical evidence, you can see exactly what this chaos looks like inside the body. These lesions completely disrupt normal, smooth anatomy. The inflammation forces tissues and organs to literally stick together, creating dense, painful webs of scar tissue that we call adhesions. In severe cases, the pelvic organs can become so fused together, it creates what's known as a frozen pelvis.
And here is a huge reason this disease is so frequently missed by inexperienced surgeons. Endometriosis is a total chameleon. Not every lesion is that classic dark powder burn spot. Highly active lesions can be completely clear or bright red. Older lesions might look black or brown, while fibrotic, scar-like lesions appear white or yellow. It literally requires a highly trained, specialized eye to spot the full spectrum of this disease on a surgical monitor.
Okay, so because these three conditions frequently exist together in the exact same body, trying to parse out the symptoms can feel impossible. But grouping them into specific clusters really helps clinicians recognize the distinct patterns of what's happening.
Let's break this down. While endometriosis heavily triggers widespread pain, pain with sex, and intense GI or bladder dysfunction, adenomyosis is much more frequently characterized by the bleeding cluster. We're talking massive, heavy bleeding, large clots, and a heavy, tender uterus that literally feels like a bruised muscle. Then there's chronic endometritis, which often presents as a stealth cluster, featuring subtle spotting or unexplained infertility. Recognizing which of these clusters you fall into is absolutely key. And this brings us to the ultimate mismatch, which is a major reason these diseases are so deeply misunderstood. The medical staging, meaning how much disease a surgeon visually sees, does not neatly match a patient's pain level. Someone can have stage 1, minimal visual disease, but experience debilitating nerve-crushing pain. Another person might have stage 4, with severely fused organs, but have surprisingly fewer daily symptoms. Stage does not equal suffering. Your pain is valid regardless of what the visual stage says.
So how do we finally get the right answers? Well, finding the right diagnosis requires using the right tools, because mapping out 3 distinct conditions demands very specific medical approaches.
While a top-tier, expertly read ultrasound or MRI is fantastic at catching the thickened walls of adenomyosis, diagnosing endometriosis is a lot trickier. Imaging is great for spotting deep disease, but a normal ultrasound never rules out superficial endometriosis. Definitively confirming and mapping it usually requires a specialist surgeon to physically look inside the pelvis via laparoscopy. And that third condition, chronic endometritis, that requires a physical biopsy of the uterine lining to actually test for the inflammation.
Because these conditions are systemic, meaning they impact everything from central pain processing to bowel function, a quick 15-minute appointment with a general doctor is rarely going to be enough to manage the whole picture. The medical guidelines point to a phased approach. This means blending medical management, like targeted hormonal therapies to control the heavy bleeding of adeno, with expert surgical excision to physically remove the rogue endo tissue, and utilizing targeted antibiotics to clear out the inner inflammation of chronic endometritis.
The crucial takeaway here is that a complex, whole-body disease requires a collaborative, whole-body team. You aren't just dealing with a uterus. If your bowel is impacted, you need colorectal support. If your nervous system is in overdrive, you need a pain clinic. If your pelvic muscles are locked in a painful spasm, you need a pelvic floor physical therapist. It takes a village.
Validation is the very first step toward healing. Seeing the science behind the inflammation, the disrupted junctional zones, the rogue lesions, it proves that this is a tangible physical battle. It is not in your head. The biology is right there on the screen.
Now that you understand the distinct geography and the overlapping chaos of endometriosis, adenomyosis, and chronic endometritis, I have to ask you something. Is your current medical team mapping out your entire reality, or are they still just throwing birth control at a structural disease? You have the power to demand better care, so will you?